Good afternoon, and thank you for coming to this talk. My name is Sarah Budney, and I'm a third-year resident at Alternate Clinic Foundation in New Orleans, Louisiana. I have nothing to disclose. So morbidly obese patients, they're at an increased risk of many different comorbidities, particularly GERD, as well as hiatal hernias, with rates of these approaching 70% and 40% respectively. Hiatal hernia repair has been shown to be safe to perform at the time of bariatric surgery and can also help to prevent provoking or exacerbating GERD symptoms down the road. However, there's not been very many studies that discuss the rate of recurrence for these patients, nor have there been many studies that look at whether one type of bariatric surgery recurs more frequently, for example, lap sleeve gastrectomy versus Roux-en-y gastric bypass. So our study really sought to address these last 2 points. To do this, we completed a retrospective chart review of patients undergoing either a laparoscopic sleeve gastrectomy or a laparoscopic Roux-en-y gastric bypass, particularly for bariatric surgery from 2012 to 2021. 2012 is when our electronic medical record was implemented at the clinic system. We searched for these patients by ICD-10 codes, and then we included patients that were having surgery performed at our bariatric center of excellence. We reviewed these operative notes to identify patients who did have a concomitant repair, and then we collected data including their demographics with comorbid conditions, operative details such as the hernia size and the kind of repair that they had, as well as bariatric data, and then we stored this in a secure database in REDCap. The primary endpoint was the rate of clinically significant hiatal hernias after a concomitant repair with bariatric surgery. We define this as a patient who had symptoms of GERD, as well as a diagnostically proven hiatal hernia, whether this was done on an EGD, CAT scan, or an upper GI. Other things we sought to address were the rate of GERD recurrence, the time to recurrent GERD or hiatal hernia, changes in the comorbid conditions, as well as bariatric outcomes. Our initial query of the system returned with 3,400 patients as having undergone either a lap sleeve gastrectomy or a Roux-en-y gastric bypass, and we had about 1,200 of these that were performed at an outside institution. We reviewed the remaining operative notes, and we were able to identify 348 patients who also underwent a concomitant hiatal hernia repair, and the vast majority of these patients were done with sleeve gastrectomy. We then went to compare their demographic data, and there wasn't a difference between the sex, race, or preoperative BMI or percent excess body weight. However, the Roux-en-y gastric bypasses did tend to be older. And then moving on to the pre-op comorbid conditions, we looked at hypertension, diabetes, GERD, OSA, and heart failure. And to trend these over time, we looked at how they were being treated medically, so how many of the patients with hypertension were on medicines, how many patients with diabetes were on insulin, et cetera. And the only difference with the pre-op comorbid conditions was with the patients with GERD, where the Roux-en-ys had a higher proportion of patients with GERD. Looking at the operative details, the sleeves had a much higher rate of patients with a small hiatal hernia, and the vast majority of those patients underwent an anterior repair. And then when we get to our primary endpoint, looking at the rate of symptomatic hiatal hernia recurrence, we didn't find any difference between these two groups. Overall, the sleeves had about an 8.1% recurrence, and the Roux-en-y gastric bypasses at 11.5%. When we looked at the time to recurrence, however, we found a statistically significant difference in the rate to both recurrent hiatal hernias as well as those with symptomatic hiatal hernias. The sleeve gastrectomies were recurring at just about 3 years, whereas the Roux-en-ys were about 1.5 years out. We didn't find any difference, however, in how these patients ended up being treated. So given we had such a large number of patients in the sleeve group who had just a small hiatal hernia with an anterior repair, we felt that many of these probably weren't getting a formal dissection of both the crura with an esophageal mobilization, so we decided to perform a secondary analysis where we excluded these patients from both the sleeve gastrectomy group and the Roux-en-y gastric bypass group, and then this is our new sample size. When we look back now at the operative details, there was no longer a difference in the hiatal hernia size, nor the kind of repairs that they were getting. And then when we go on to look at recurrence data, there was still no difference in the rate of recurrence for either GERD or hiatal hernias. And then we no longer had a statistically significant difference in the time to either GERD or hiatal hernias, although it was definitely trending in that direction and still pretty clinically significant. The Roux-en-Ys were recurring at, again, just about over a year and a half, whereas the sleeves were recurring at about 3 years out. Looking at the bariatric outcomes, overall, really no statistical significance. The Roux-en-Ys did tend to lose more weight. Our 30-day complication rate was very low, and none of these were mortalities. The sleeves, a few of them were staple line bleeds, and then surgical site infections. And for average follow-up, the sleeve gastrectomies had a lot longer length of follow-up. This is just a review of the comorbid condition changes over time. It kind of just reflects literature that's already out there with each of them improving over time. So in conclusion, our rate of GERD recurrence was about 30% for the sleeves and 38% for the Roux-en-Y gastric bypasses. And the rate of recurrence for symptomatic hiatal hernias was 8.1 for the sleeves and 11.5 for the Roux-en-Y gastric bypasses. And this was not statistically significant. Interesting though, all of the patients who had a recurrence except for one, had an anterior repair. And this held true for even the patients who had an asymptomatic recurrence. And while recurrence rates weren't different, the Roux-en-Y gastric bypasses did recur earlier, and they also tended to lose more weight. This study is limited by its retrospective nature, and I think the big limitations are the way we define GERD, as well as our hiatal hernias. So GERD, we basically went through the notes from their follow-up visits and saw if they were complaining of any symptoms. They did not have formal diagnostic studies like a pH probe or an EGD showing esophagitis. And then for the hiatal hernia recurrences, we were looking for diagnostic studies that showed them. It was also performed at a single institution, and then our sample size in the Roux-en-Y gastric bypass group was fairly low compared to the sleeves. So looking forward, I think one of the questions that I walked away with from this project was, most of our patients who had a recurrence had an anterior repair. And so there were patients who likely may not have even needed this, or if they were going to get a repair, is it more appropriate for us to do a full crural dissection and repair either posteriorly or close the crura on both sides? These are my references, and I will take any questions.